Good evening, everyone, and welcome to our ninth session of the Mimic series. The series is designed to empower clinicians and healthcare providers, and for everyone who is interested in learning more about genomics, how it is being utilized across various clinical and healthcare settings. I'm Aarti Dara, your host for this webinar, working as a bioinformatician at Partners Healthcare. Today, we have with us Dr. Swaratika Majumdar, who is working as a consultant at Majumdar Shaw Medical Center. And today, she will be speaking about gastrointestinal stromal tumors and the insights on mutational analysis on these tumors. Before we all listen to her insightful presentation, I would like to take this opportunity to introduce her. She has obtained her MBBS degree from GSS Medical College and pursued her specialization in internal medicine at the esteemed CNC Vellore. Her journey continued as she excelled in a field, achieving a DM in medical oncology from Tata Memorial Hospital, Mumbai, where she was honored with a gold medal for her outstanding performance. Dr. Majumdar's area of expertise lies in thoracic, head and neck oncology, as well as sarcomas. With a deep-rooted passion for delivering high-quality cancer care, she remains committed to making a difference in the lives of her patients. Thank you, Dr. Majumdar, for joining us. The stage is now yours.
Good evening, everybody, and thank you especially to Dr. Vinod Skaria for giving me this opportunity. So before starting, I'd like to say that it's a very brief presentation, and I would like it to be a discussion, and more so that we could have and answer each other's questions rather than it being a direct talk only from my end. So today, this evening, we will be talking about mutational testing in GIST. And mind you, all of you are probably molecular oncologists, but I'm a clinician, so your knowledge in this area will be far more than mine. But this is the basics of what I know and what I have learned. So we'll go through the epidemiology and histopathology, the brief molecular pathogenesis, and we'll discuss a bit about mutational testing, whether it's germline, somatic, or secondary mutations. So first, coming to the epidemiology, GIST, as we know, is not a very common tumor. So it's predominantly, in the Western world, there's a varying difference in adult GIST, though the median age seems to be 65 to 69. However, we see it almost 10 years earlier as per small hospital-based retrospective data that's been published. Pediatric GISTs are even fewer, comprising of 0.4% of all the GIST. Unfortunately, we don't have robust data from India about this at all, but the median age of presentation reported is around 15 years. Typically, the gender overall in the world is 1:1. There is no female preponderance, but in India, it's been largely reported to be slightly male preponderant, around 2:1, and this has been consistent across all the hospital retrospective analysis that is available on public literature. So geographical distribution, again, it's predominantly the Southeast Asia and Norway and a lot of the Scandinavian countries. But I think it's because of more robust data keeping and publication of such rare tumors. So the true geographical distribution of GIST will largely remain unknown. Coming to pathology, so GIST in its full form is obviously gastrointestinal stromal tumors. So with that, we know that they are mesenchymal tumors involving the gut. They comprise of 1 to 2% of all GI neoplasms, but of the sarcoma and the mesenchymal tumors, they remain the most common. The cell of origin is the interstitial cell of Kajal, which are also known as the pacemakers of the gut, because they typically lie within the bowel wall during embryogenesis. They give rise to subepithelial neoplasms. The diagram depicts the frequency. Predominantly, it's gastric, around 60%. We have reported up to 70%. Then comes the small intestine with jejunum, ileum predominating. Then next common is the duodenum. Colorectal is 4%, and appendix and esophagus is less than 1%. Having said this, GIST can also well, not just, but similar stromal tumors can also arise from areas which are not related to the gut, like the omentum, the peritoneum, the lungs, and the bronchus. And it's theorized that probably during embryogenesis there was some interstitial, similar interstitial cells of the child which have remained there. Though predominantly we'll restrict ourselves today to gut cysts. Pathology can also be varied because they can be spindle cell-like, as seen in figure A. It can be epithelioid, as seen in figure B. And there can be a combination or variants of both of these two. They can also have a large, number of collagen-like fibers, in which they're called sphenoid, typically seen with neurofibromatosis. They can also have a very high mitotic rate and very atypical looking cells, and then you have a sarcomatous variant. So based on pathology per se, we do not make treatment decisions. They might have they do have bearing on the risk status, because we grade it depending upon the size and the mutational status, but not based on the histopathology alone. Though we know that, if you have a spindle cell with a low Ki index, the chance of you, one, getting mutations is probably less frequent, and the chance of you having a very indolent course is more likely, as opposed to an epithelioid variant with a higher Ki index. So coming to immunohistochemistry, before the standard immune markers that we use now came, we had CD34, which is essentially a vascular marker. They used to come positive. Now we know that it may come positive, but it's neither sensitive nor specific to GIST. One of the more interesting markers is DOG1, which is discovered on GIST. It's essentially a chloride channel called anonectin 1. It's specific, it is sensitive, but of course, like all medical theories, it is not absolute. You could have potentially DOG1 negative GIST also, but it just complicates the diagnosis of GIST. The other frequent marker that we always do is CD117, which is nothing but the phenotypic or the protein expression of the KIT. So CD117 is pathognomic, because although it's not specific, you do have other tumors which do express CD117, but in the presence of the correct clinical and pathological features, CD117 and DOG1 are largely pathogenic of GIST. So if they are positive, we do confirm GIST and we move on to mutational testing. But if it is negative, again, like I mentioned, GIST can never be ruled out because it is the most common. But we then proceed with a very intense panel on trying to exclude other markers, other pathologies, like inflammatory fibroid polyps and low-grade sarcomas and other spindle tumors that you could find there. However, because if SMA, desmin, S100, etc. positive, we know it's a non-GIST. But if it is negative, it still could be a GIST, and that's when mutational test comes in handy. So this is a larger feature, as you can see how common. We'll go bit by bit. So we can see the larger, the blue slashed line, which is all CD117 DOG1 positive. And you can see that's a big broad line because most of our GISTs are CD117 and DOG1 positive. Within this, you can see a nice orange square. So we know that these are the tumors which are either KIT or PDGFR alpha positive, which I will speak about subsequently, and that comprises of 85%. You can see there's a small, portion above the blue line, but below the orange line. I don't have a pointer, so I'm just going to describe it. And that is the fraction of patients which come around 5 to 10%, 15 to 20%, which are both negative for KIT, PDGFR, and other mutations. You could have a mutation That is the frequency of patients who are CD117 and DOG1 negative GIST, yet they still harbor pathogenic mutation. And that is why it's important to move beyond IHC in diagnosing GIST, especially when the immunohistochemical markers are negative. Now, moving to the right side of the diagram, we can see that they are CD11 positive and DOG1 positive, yet there is a 10 to 15% chance or 10 to 15% frequency of it being KIT and PDGFR negative GIST. So this highlights the fact that even if you have a tumor which is strong CD117 positive, it doesn't automatically mean that it's going to be KIT mutated as well. That is something we need to realize, especially because it's a common trend to start therapy just based on CD11 expression, which may not harbor a pathogenic KIT mutation. Mutations are then divided into somatic and germline. The majority of the mutations in GIST remain somatic because of its rarity, and germline mutations comprise of around 5%, which I will be speaking about. So coming to molecular pathogenesis. So what is KIT and what is PDGFR, right? They are transmembrane proteins. They belong to the tyrosine kinase type 3 receptor, and they are mapped to chromosome 4 long arm 1, 2. So KIT is essential in the interstitial cells of Cajal. They develop it, they aid in gut motility regulation, and they also play a part in development of melanocytes and mast cells. So it's often confused, or you can have mutations which coexist with malignant transformation of mast cells and melanocytes as well. Briefly, the KIT exons around, which lead to GIST cluster around 11, 9, 13, 17, and 8 in that frequency. I will speak about it, but essentially what it does is that they are activating mutations, and they cause constitutive activation of the tyrosine kinase receptor, leading to protein expressions, leading to oncogenesis. So one of the important things is that phenotypically, you cannot distinguish a PDGFR alpha and a KIT, though sometimes PDGFR do not express CD117, but essentially they produce similar tumors and they tend to be mutually exclusive. So coming to, this is the transmembrane diagram of the same. We'll first concentrate on KIT. So KIT basically has, extracellular domain, which is coded predominantly by exon 9, a transmembrane domain, which is coded predominantly by exon 11. And it's at this point that it basically binds to the ATP binding protein or ATP binding enzymes, right, leading to the ATP activation and consequent phosphorylation of proteins. So downstream, you have the intracellular part, which is coded by exon 13, 14, and 17, and 18. This diagram sort of represents sensitivity to imatinib as well, because the upstream ones, 8, 9, 11, predominantly 11, are largely sensitive to imatinib in varying doses, but the downstream that you go, the area where imatinib acts is already surpassed. So more downstream mutations like exon 18, 17, 13, they tend to be resistant to imatinib. Coming to the other important protein that we have, which is the PDGFR alpha. This is also like a very close cousin of. It is also a transmembrane protein. It has an extracellular domain and an intracellular domain, predominantly because most of the pathogenic mutations lie in the transmembrane or the juxtamembrane and intracellular domain. They are predominantly may be resistant to imatinib. So the most frequent of this is exon 18, which is 6%, and the others are exon 12 and 14, which are quite rare. Interestingly, exon 18, there are two classes of mutations. One, which is D842V, which we know in all its variations to be very common, of the PDGFR and largely resistant to imatinib, but the ones which are D843Y are actually quite sensitive to imatinib. So, it's a reminder for us clinicians also to not just look for pathogenic mutations, but also to look at the kind of pathogenic mutations we get. So like I mentioned before, we'll just concentrate initially the diagram onto the left of the page. Like I mentioned, the KIT as well as the PDGFR they behave in a similar manner, and they have a activation loop, and they basically set off a lot of cascades of reaction which affect multiple cell stimulatory pathways. Chief pathway is the RAS pathway. Another pathway is the PIK3 AKT pathway, and they all boil down to the mTOR pathway. So the importance of realizing these pathways is that when mutations develop, or if you have an innately resistant mutation, it helps us altering or trying other targets of treatment. So first I'll address germline mutations, and then I'll address somatic mutations. So the genetic syndromes which are associated are quite rare, because we should remember the GIST is rare. 95% of the GIST is largely somatic. So 5% or 0.4% of all GISTs overall are actually, are associated with a genetic mutation or a genetic syndrome rather. So phenotypically, they're quite indistinguishable from sporadic GIST. They're divided into two. One is a primary GIST, where you have germline KIT or PDGFR alpha mutations or which are inherited. And you have secondary GIST, which is associated with known syndromes like neurofibromatosis and Carney-Stratikis syndromes. So, if a patient walks into the OPD, when do I suspect that the patient requires a genetic evaluation? If there are multiple GISTs, if they have distinctive phenotype of other syndromic harbingers, or simply if they are very young, like a person in their 20s, or if they have family history, because you're not expecting GIST in younger population. So these are sort of like just a mental tick to note and keep it in consideration, especially if you have a KIT and PDGFR negative tumors. So before I go in, I just want to describe this diagram because it implicates a lot of our germline GIST. So like I mentioned, the RAS-RAF pathway, as well as, the PIK3 AKT pathway, and finally the JAK-STAT3 pathway, which sort of all boil down to mTOR inhibition. But the one genetic syndrome that is not related to the KIT per se or the PDGFR per se is the succinate dehydrogenase deficiency, which I will talk about the pathology here, and finally the mutation later. So here, as we can see, inside the mitochondria is the succinate dehydrogenase enzyme. It basically dehydrogenates the succinate. In its deficiency, succinate accumulates. As a result of this, there is an accumulation of pro-oncogenic proteins like HIF1 alpha, and as well it can also translocate and cause autophosphorylation of DNA, leading to more oncogenic mutations. So essentially, it's the accumulation of succinate which sort of activates a phenotype which is similar to PDGFR and KIT, though it is not affected by that, and it leads to GIST formation amid other tumors. So first, we'll do the primary syndromes, which are KIT. They are predominantly autosomal dominant. As a result of that, there's no sex predilection. They come, like I mentioned, in the Western world, The average age of presentation is in the 60s, so you get them a decade earlier in 40s and 50s. But in India, the average age of presentation seems to be early 50s or the fifth decade, or maybe even late 40s. So then we might have to presume it might be in the 30s, though we don't have data supporting that. The whole of the gut can again be involved, though they tend to be more small bowel predominant. In the presence of KIT deficiency, there is an overall interstitial cells of Kajal dysfunction as well. So they have a lot of gut motility issues, which they might present with earlier. And they also, because they are involved in melanocytes and mast cells, they also can accompany skin pigmentation defects. So they might have lentigines and vitiligo, especially both of them coexisting. Okay, but but they don't have to be there. They may be there. And predominantly, like how how we study classically germline mutated tumors like FAP syndromes, where they start with hyperplasia, dysplasia, adenoid polyposis, and then go on to invasive cancer. Similar to this also, that there is a polyclonal hyperplasia of the interstitial cells of Kajal, what is called as ICCH. These are precursors, but of course they're not malignant because they're polyclonal, but then they go on to become cysts. And you can see in the resected specimens, you can see areas of this happening. So when you look at KIT mutations in those who have inherited it, are they different? Yes, they are slightly different. Exon 9 and 17, which are rarer in sporadic cases, 17 especially seems to be more common in germline mutation, again confer around 11% versus 1%, conferring a sense of imatinib resistance. And even in exon 11, I will describe further, deletions tend to be more common, almost 60% in sporadic cases. However, this ratio is rightly reversed because in inherited substitutions seem to be more common than deletions. Of the substitutions, these are the mutations that I've listed predominantly in the short arm substitutions, which are more common in germline, around 48% versus only 10% in sporadic. So you do have unique sort of different KIT mutations in these patients, and that might have a therapeutic implication as well, because if you have a higher frequency of 17, they may not be imatinib sensitive. So now coming to PDGFR mutations, they're definitely less common than the primary KIT mutations. They're also autosomal dominant. However, they have a slightly, they have a predominantly female, which has been reported from 4:11 male to female ratio. So they're predominantly female. It's supposed that maybe PDGFR might be more harmful, and therefore, or their expression, or because of the epigenetic changes, might be more in women, and therefore they manifest more in women. KIT mutations tend to be in the small intestine, while PDGFR mutations tend to be typically gastric. They tend to be epithelioid, at least in part. And what is characteristic is that they have a weaker expression of CD117. And these are unique because they're characterized by the inflammatory fibroid polyps rather than instead of interstitial cell Kajal hyperplasia. And that is what you will see in the pathologies, any resected samples. And although there is no explanation, they are also associated with lipomas, and the patients may tend to have larger hands. So these are some, clinical characteristics which we sort of look for when we're trying to see if the patient requires a germline evaluation. So mutations in PDGFR, PDGFR alpha as such is not very common. So the data that's available is not very robust. Exon 18 mutations are certainly higher risk, although they are more common in sporadic than in germline, as opposed to lower risk mutations which predominate in germline. So this is something we see in most germline disorders, where the better mutations sort of stick and the patient perhaps lives to develop GIST, and maybe the more higher risk mutations have other disorders which which may affect longevity to developing GIST. Then we come to syndromic GIST, the most common of which is neurofibroma associated, that is NF1. We know it's an autosomally transmitted defect on chromosome 17. Only 1.5% of GIST are NF1 associated, though 7% of NF1 can go on to have GIST. And what is interesting is that, GIST, if you do an NF1 by IHC, nearly 45% of them express NF1 protein on the cell. They may not be, they may not have NF1 mutations, because that's quite rare. So similar, because the pathway is very similar to KIT mutation, though it is distinct from it. They also lead to interstitial cell Cajal dysfunction, leading to its hyperplasia, dysmotility. They might have neuroendocrine tumors, and of course, they'll have the classical phenotype of NF1, which we use for clinical diagnosis. Just in NF1 associated cases tend to be multiple. They are distributed, though they are more predominantly small intestine than gastric. They have sphenoid fibers on pathology, which is basically spindeloid, but they sort of have like these collagen globules interspersed between them, which is indicative but not pathognomic of NF1 associated GIST. And the treatment implication is basically that all of which is not KIT dependent will always be imatinib resistant. So we do not give them treatment with imatinib. Coming to the second syndromic association of germline mutated GIST, which is the SDH deficient GISTs. SDH is a Krebs cycle protein. It is basically an enzyme. It is present inside the mitochondria. It has 4 subunits, A, B, C, D, and all of them are mapped on different chromosomes or different loci of the same chromosome. They all lead to essentially a phenotypically similar GIST. Okay, almost exclusively these GISTs tend to be gastric. They tend to be a plexiform type. That is, you have a lot of fibers which intermingle with each other on the pathology slides, and they are DOG1 and CD117 positive, as opposed to PDGFR mutated GIST. And one way of identifying them, of course, is that you have a patient who is very young, because this is the most common mutation seen in pediatric GIST. In its syndrome presentation, what it typically is the Carney-Strateke's syndrome, which is a paraganglioma and a GIST which coexist. Typically, the GISTs come in 20s. This is a germline mutation. They tend to be autosomal dominant with incomplete or variable penetration. So you can have GIST of varying severity. And they typically involve the subunit B, C, and D. And they are also preceded by microgist. So because SDH doesn't involve development of the interstitial cells of Cajal, they are not associated with any of the motility disorders or hypopigmentation. Instead, they are more associated with paragangliomas and other neuroendocrine tumors and pituitary adenoma. So Carney's triad is just that, with pulmonary chondromas. They can precede and succeed. There is no set story that the pulmonary chondroma has to precede, or paraganglioma has to precede the GIST. This is not actually autosomal dominant, but it's more like a genetic mosaicism, which basically leads to epigenetic changes in the SDHC gene. They are typically female, although they have strong female predilection, but they are also preceded by microgysts. So salient points of this syndromic GIST is that in the pathogenesis of GIST, when the GIST has a mutation, when there is a KIT or a PDGFR mutation, the mutation alone does not always lead to GIST. There might be other translocation abnormalities, which is typically 1p or 20 22q loss. This does not bear those chromosomal imbalances. So, getting a fish done is another way of identifying. And they're typically indolent. Although they're indolent, they tend to involve the nodes, lymph nodes, which the sporadic gist or KIT PDGFR alpha gist don't involve the lymph nodes. So what happens is, typically when the surgeon sees a gist on imaging, we resect only the gist. We do not resect the nodes. However, in STH mutated gist, we should consider it because 50% of the relapses occur within 2 years at the lymph nodal sites because they were there to begin with, probably. But even if it relapses, you can always offer a second surgery because they are typically very indolent. The typical risk stratification of KIT mutated gist obviously does not fit into it, and they are not sensitive to imatinib, and you might have other associated tumors, like I mentioned, pituitary adenoma, renal cell carcinomas, paragangliomas, and pheochromocytomas. So now we come to somatic mutations. Somatic mutations, basically we test it on the block, not on our cells. Why we must and we should do it? Because there is a therapeutic as well as prognostic implication. So the current risk assessment guidelines for GIST typically concentrate on the site. So worse prognosis for for non-gastric GISTs, worse prognosis for larger tumors, worse prognosis for tumors with high mitotic rate or Ki67 index, and presence of necrosis. So these typically determine its prognosis. However, we know that some mutations fare better than the others, and therefore there is some prognostic implication. There is a definite predictive implication because we tune our adjuvant as well as treatment of metastatic disease based on somatic mutations. So whom should we test this on? All, even early GIST, resected GIST, GISTs which are kept on observation as soon as we do a biopsy. Ideally, we should test all. The only exception is, and that is also, like quote unquote, we could consider an exception as per both NCCN as well as the ESMO current guidelines, are rectal GISTs which are less than 2 centimeters in size. Non-rectal GISTs which are less than 2 centimeters size. So basically, very small GISTs, maybe you could exclude, but predominantly it's, whoever you're treating, you should consider doing a somatic analysis. So how do we do it? There are 3 ways. RT-PCR, Sanger sequencing, as we know, to be very cumbersome, and the modern day do-it-all test, which is the NGS. And I'll speak a little bit about this because it's important from a clinician's perspective. So when we sit and we're counseling the patient after diagnosis or the expensive surgery, to convince them to undergo mutation testing is quite difficult. We start with an RT-PCR because that's going to pick up almost 80% of my mutations. However, if the RT-PCR is negative, then the question arises, should we do a broad panel or a comprehensive NGS for it? And these comprehensive NGS should also, sort of include, depths up to 10,000 to pick up things which are low VAF. However, although they can have pathogenic mutations, again, why do we need to do it? Just to, decide treatment, because the kind of mutation we have is so important for imatinib sensitivity. Other mutations or other fusions that we pick up is also BRAF, NTRK fusions, and picking up of other mutations which might be seen in an in a KIT PDGFR wild type samples. And then suppose both are negative, you do or you do not do an NGS because the patient can't afford it, then the next thing in line that we do is evaluate for germline mutations. And we start with a simple IHC of SDH and NF1. If the SDH is deficient, then it's clearly you go down one route. If the SDH is proficient, then I think the only route that you can go through is NGS, because you need to see if you can pick up other potentially therapeutic mutations. So in somatic mutations, KIT is the most common. They are typically in frame mutations. They occur along exon 9, 11, 13, 17, and 8. And the deeper we go with our testing, the more mutations we're going to be picking up in the near future. What's interesting is that although 90% of KIT mutated will express CD117, CD117 negative tumors can also be just mutated, KIT mutated. And it's important to send it for that analysis, not just for diagnostic, again for therapeutic implication as well. In our worldwide, 80% of GISTs have KIT mutations, though the hospital-based series published gives us numbers of 52% to 70%. And presence of mutations are also proportional to the size. So the larger the tumor, more chances that you're going to have a pathogenic mutation. And that is why perhaps mutations, tumors which are less than 2 centimeters or very small, can be spared mutation testing, though I think, we usually do not. Coming to what part, so the other thing I just wanted to mention about the in-frame mutation is that although there are certain hotspots, they are not, they're not the same every time. So you have these mutations like BRAF V600E, right? And that is so consistent. You can take it up with IHC, you can diagnose it with a simple RT-PCR, and that will pick up the exact thing. Unfortunately, for KIT mutations, it is not. You can have so many differing mutations within the same exon that a simple test or a very limited PCR may not be able to pick it up. So I've highlighted the presence, the prevalence of or the frequency of different exons in KIT mutated GIST. The red ones are highlighted in red. So exon 11 seems to be universally very common. That is 66 to 77%, and 57% in India. Exon 9 is the next most common, 13% and 10% in India, which is more or less similar. Exon 13 and 17 are rare, comprising of 1 to 3%. So although these are extremely, like I mentioned, there's so many mutations, and like I mentioned, the deletions were more common than mutations. What I would like to highlight is exon 11, deletions in 558, 557 region. And this is important, especially for a clinician to pick up and read about, because they're resistant. Even though it's an exon 11 mutation, even though it's a deletion, which is the most common type, in the 557, 558 region, they tend to be resistant to imatinib. Also we must realize that even though classically we're taught that exon 11 mutations are sensitive to imatinib, all exon 11 mutations are not sensitive. Commonly, though, they tend to be, not all. So this, whenever we get the report, it's sort of like a reminder to us, for us as clinicians, to check whether that particular mutation is sensitive to imatinib or not. So exon 9 mutations are obviously not as common. They're only 10 to 19, sorry, 10 to 13%. But what's unique about exon 19 is that they still have some level of imatinib sensitivity, though we have to give it in a higher dose. So typically we give 400 mg of imatinib to exon 11 mutated GIST, but for exon 9, we give it at 600 mg. That's the only difference. So coming to why do we need to test, and do they have an implication on outcome? So there was a larger meta-analysis done correlating outcome to the mutation status, and they have found that DFS events are definitely more in exon 9 than exon 11. So they are prognostic. Exon 11 do tend to fare better than exon 9. And secondly, within exon 11, are there any things which sort of deletion versus substitutions. Do they matter? Yes, they do. Deletions tend to be worse than substitutions. So even though deletions are imatinib sensitive, those particular type is not, they tend to do worse than substitutions. Coming to PDGFR mutation, which is the next most common, the prevalence ranges from 5.8 to 8.2. So 80% of your tumors is still KIT. The rest, around 5 to 8%, is PDGFR alpha. They involve exon 18, 12, or 14. 18 being the intracellular domain, and that is most common, which is 15%. Like I mentioned, most by rule of thumb, exon 18 mutations are imatinib resistant because the mutation occurs downstream to where TKI acts. However, exon 18 D842Y are imatinib sensitive, and that is why we need to check the report properly. So coming to the third category of somatic mutations. So you have KIT mutations, you have PDGFR mutations, and now we have PDGFR and KIT wild type. So I'll just spend a little time on this because it's a complex, but it's a very nice diagram which explains it a lot. So first, we can just start with the blue part, okay, which is one, which is so once it's wild type, we do an SDHB IHC expression, and we check if it is proficient or deficient. And then the part one, which we know to be less common, is that they very rarely tend to be SDHB proficient with normal expression. So in this one, you can see that the mutation status, which is the part D of the diagram, they're correlated to NF1 mutation, RAF mutation, ARID1 mutations, fusions, NTRK fusions, and all these different genes. While if you see 2 and 3, they are SDHB non-expressors, which can be related to a mutation, or it can be related to the epigenetic methylation. And both of them tend to be, more sort of associated with obviously SDH mutations. Of the part which you can see is the smallest circle, which is the gender predilection. You can see that in the SDH proficient tumors, they tend to be matching, male, females tend to be matching. When you see SDHB mutation, that is the part which is true or light pink, beigeish, they are also slightly female predominant, but they tend to have more men. But the one which is SDHC methylated, they tend to be predominantly female, which is what we had seen in the triad. The Karnowski triad. But of course, these are very rare events. So coming to survival by GIST subgroup. So in the wild type, if they are competent, SDH competent GIST, their survival tends to be better. They are very indolent, while those which are mutant or epimutant, they tend to have a lesser or more aggressive disease. But like I mentioned, because they are so rare, we do not have good data for it. So coming to the last concept, and it emphasizes why we need to do more NGS in GIST, especially if they are KIT and PDGFR alpha wild type. One is to check for BRAF because they are a potential therapeutic target more often than BRAF V600E mutation. There's case series and reports of BRAF fusions. They typically are weak with, they do not have a very strong CD117 expression. And they also drive tumorigenesis and through MEK inhibition. And they are, so because they occur downstream, they are not very sensitive to RAF inhibitors, what we typically use in BRAF V600E mutations. The fusions have a different way of acting, so therefore they are not sensitive to RAF inhibitors, but they are sensitive to MEK inhibition. So that's another potential target, or mTOR pathway targets, which are more downstream. The other cohort of potentially targetable patients are NTRK fusions. Again, we do not have, it's reported in less than 1%. They're mostly case series and case reports, which are just coming up. Unfortunately, because you check for 1, 2, 3, but the targets, but what really acts, or what we have a therapeutic target for, is NTRK3 alone. And thankfully, in GIST, its partner with ETV6, NTRK3 is the most common sort of fusion seen. Of note is that NGS might sometimes miss it, and we might be able to pick it up in break apart probes of NTRK fusion, just because we do not always have an adequate partner. So, we don't know what to test sometimes. But these differ from BRAF fusion tumors in being CD117 positive. So coming to our Indian data, I have already mentioned it, but this was a very nice study. And I'll just highlight, it was a retrospective data presented from AIMS. And I'll just highlight that the 2-year OS is in c-KIT exon 11, it's almost 88%, while, in exon 9, it's 75%, which is far greater than in exon 18 and SDH mutant tumors. But what is nice to see is that the wild type GIST, which is probably NTRK or NF1, tend to do better than the SDH and PDGFR exon 18 mutated GISTs. Coming to last part of my presentation, which is in the era of treating metastatic disease, you have TKI resistance. So is there value in testing? One is that we know that 50% of them do develop some imatinib resistance. And although there are several epigenetic, microRNA, energy metabolism, and several more complex pathways, what we can detect considerably is genetic mutation. Does it have a therapeutic implication? I'm not sure yet, because we do tend to target these tumors with broader TKI inhibitors like Stutint and Regorafenib, etc. I'm not sure, but the most common mutation that we do pick up is again in exon 13 and exon 17. And secondary PDGFR mutations, especially of exon 18, are very, very rare, though there's been only one report of it. And it's always good to just do other mutations that we know have an implication in prognosis, especially P53 or MYC-related mutations, which, it helps us prognosticate the situation to the patient that we know it's going to have an aggressive clinical course. So in conclusion, all GISTs must undergo mutational testing. As a clinician, whenever I get a report, I look at the mutation and I do either discuss it with a molecular pathologist, or I'll go back and read to see if the sensitivity is retained and at what dose of imatinib sensitivity I'm looking at. And also, I think there's emerging data for secondary mutation testing and also a comprehensive NGS testing at baseline itself, though perhaps maybe it might be useful in only 10% of your patients. So that's all from me. I'll be happy to take any questions.
Thank you, Dr. Majumdar. It was really a comprehensive presentation. And it's something which is at least very new to me. When I heard about there are so many subcategories of GISTs. So my first and foremost question would be, should universal germline testing be offered to all patients with GIST?
Yes, we do. With the only exception is tumors which are less than 2 centimeters. So, you basically pick these up incidentally while doing endoscopy for dyspepsia, or, you're evaluating another malignancy, you're staging them, and then you pick up an incidental GIST, which you may or may not treat because it's picked up incidentally. And it's not always, it's not a polyp. It's covered by a mucosa. You'll have to, the surgeon or the gastroenterologist has to cut through the mucosa and submucosa to the muscle layer to sort of remove that tumor, which is not commonly done. So we don't we don't do that. So if it's less than 2 centimeters and we're letting it be, then we do not need to do the mutational testing.
Interesting. Uh, so how, and you also talked about that the role of germline mutation is only 5%. It's the somatic mutations which play a part. And for somatic mutations, there are available therapies. Have you encountered anything which is related to resistance to those therapies?
Yes,
And
of
in what
course.
frequency?
Imatinib resistance is extremely common. Almost 50 to 60% of our patients develop that because, if we are smart, it's a dictum that cancer cells are always smarter. And we must remember that imatinib sensitive mutations are quite upstream. They are predominantly coded by the juxtamembrane part or the extracellular part, which is exon 9 and 11. So below that, that is below the ATP binding site where imatinib acts, all those mutations are resistant to imatinib. And what happens is, as and when you give imatinib, there is a loop, and because KIT is related to so many pathways, like you have your RAS pathway, you have your PIK3 AKT pathway, you have your JAK-STAT pathways, and also downstream to that, you have your mTOR pathways. Sort of a resistant mutation can develop at any point, which leads to a downstream upregulation of all these proteins, and therefore it will confer your imatinib resistance. So it's very common. It happens especially with GISTs which are upfront metastatic, upfront large tumors, high Ki67 or high mitotic rate GISTs which, sort of you give imatinib and they tend to progress quickly. These are all quite common. And we do have guidelines on how to treat them at progression, or at first progression and second progression also. Though, like I mentioned, it is not standard to do a repeat biopsy or a liquid biopsy to check for mutations at progression. So, so if the person is on imatinib, then we switch and they have developed resistance, we switch them to a sunitinib, etc. Irrespective, we don't do a repeat biopsy at this point, unless we are sort of suspecting a sarcomatous transformation of the GIST, which means that it's no longer a GIST, but it's degenerated and de-differentiated into a proper high-grade sarcoma. Then we give them chemotherapy.
Yes. And what do you think about the role of genomic testing in picking up these resistance markers?
Yeah, so I thought I spoke quite a bit about it, but yeah, I don't know what the implication of genomic testing at this point is, because see, your PCR will sort of pick up 80% of your tumors, and it's a cheaper thing to do, and the results also come very quickly. But of course, like I think I think the data will come on the role of broader based panel. I think it definitely has a place in KIT and PDGFR negative tumors. So if you have a wild type tumor, and then you do an SDHB by IHC, and you have a retained SDHB, then definitely we should go in for a comprehensive panel. Because you might pick, there's no other way, or at least you should go in for targeted testing. Like, okay, I will test for break apart for BRAF, I will test for break apart for NTRK. Because now at this point, you know that imatinib won't work. You don't know if all your other drugs will work. So you're just trying to see what can you find to give your patient.
Correct. And I think the applicability of using targeted panels is very much high in gastrointestinal tumors, because that takes care of investigating mutations as well as the signatures like we talked about
Correct.
NPR.
Yeah, yes, absolutely. The other thing I found very interesting is that definitely a lower prevalence of KIT mutations in our population as opposed to PDGFR. It's like much higher, like 80% as opposed to 52%. Only the recent TMH data reported up to 70%. But I don't know why that is, why India is a little different. But I think it's because, many oncologists perhaps don't send for mutational testing, and they empirically start them on imatinib, and exon 11 being a naturally sensitive mutation to imatinib, patients are probably just taking it and they are probably in control of it. And so only once they progress, or only when they don't behave well, you test it. And then it turns out it's not KIT to begin with. So maybe it's just a bias like that.
And since you talked about the KIT positive tumors, the syndromic cysts, would you like to comment on the available clinical trials that are going on in this field?
Um, so they're definitely exploring more therapies for PDGFR alpha, because avapritinib is, it's approved. There are lots of clinical trials going on, actually, depending upon at which mutation you're targeting. But they are not necessarily KIT related. They are more tumor agnostic fusions like NTRK, or tumor agnostic mutations like BRAF600E. So I think the more targeting, I think trials are becoming more and more like a sort of basket trials, where you're looking for a particular target, you know it works in a mutation, but it's so rare that you can't do it for one particular cancer. So let's just bring everything in. And that's how HER2 has progressed. That's how BRAF mutations have progressed. That's how NTRK has progressed. And I think that's how it's going to be, because pathology is going to become secondary to the driver mutation.
And before we close this session, there's last question from. How do you think we can enable genomics for all cases that oncology?
I'm sorry?
How we can what are the challenges in enabling genomics for all the patients that come with this?
I think the cost is the major issue. Most of them get diagnosed after surgery or extensive testing. For me personally, the most resistance is really just the cost, because most of testing costs around 10,000, and patients don't want to, spend anymore. There's a lot of resistance to spending, because you've been told you have a cancer, potentially incurable. They just want treatment. But yeah, I think if you do sit and talk to a patient, you tell them it's worth it. It'll save you from unnecessary therapy with imatinib. You could possibly give them better drugs. Then they might get convinced. But the major challenge is still the cost of testing more than anything else. And second one is also, especially if it's a metastatic disease, then we don't, resect, even though there is a role of debulking if the patient is symptomatic. But we do sort of, we do a biopsy, and then the tissue may not be enough for PCR testing, because you've already exhausted it with IHC, and it may not be enough sometimes. So these are the two. And then patients do not want to get a repeat biopsy done. Actually, it did not occur to me, and I haven't looked at it, but the role of liquid biopsy in KIT testing, I do not know. But yeah, maybe if the patient is unwilling for a biopsy, whether a liquid biopsy might be a substitute, I do not know.
Thank you. Looks like there is so much that we can do when it comes to this. And again, the therapeutic applications are yet to be figured out for certain subtypes.
Yes, absolutely.
Thank you, Dr. Majumdar, for your insightful presentation, and I hope everyone learned a lot about this today. Thank you all for joining in. We will again come up with a new webinar on next week and see you there. Thank you.